Hello? I can't hear you. I can't hear you. I can't hear you. Huh. Okay, we just need to work on me hearing you. I can't hear anything. Yeah. Okay, so the volume is all the way up on the phone. And that's where it is. It says audio and the microphone. It checked my microphone before I was on the show, and it said your microphone is working. That's what I'm saying. It's the phone audio. It's all the way up. You can hear me, and I can't hear you. No. Uh-uh. I don't know if it says audio, video, flip, and chat, but chat goes to something else where I'm chatting with the audience, and that's not what I want. I don't know what is going on here. Hold on. Let me close it. Let's see. I can hear. I can't hear. I still. Hello? Are you talking now, Regina? Okay. Say something. You can't hear me? You should be able to hear me. Hello? Hello? Can you hear me talking? Hello? Hello? Microphone check. Hello? Let me I hear the music. I hear. Okay. Hello? I just heard you a minute ago. I heard the music and everything. Ah, okay, wait. It's going in and out. I can hear the music now. Perfect. Perfect. Awesome. Uh-oh, now it went out. Why is the music reception coming in and out? Okay, now I hear it. Now it stopped. Michelle's World, ready to come out and play before New Year's Eve. Last opportunity. It's Michelle's World.
Hey.
Okay, I can hear you.
Okay.
Keep talking. Okay,
Okay.
now let me try to come in and see if I
Come
can
back in.
keep talking though.
I'm going to keep talking. Now we got it. We did it. See,
Can you hear me on the video?
I can hear you just fine. I can hear you just fine. We
Perfect.
got it. Okay, it just took us about 20 minutes to get it done, but we are that awesome. We're that dedicated. Okay, for those of you who are just joining us, and we do appreciate all of those who have stood around and waited.
Exactly.
We want you to understand that what Dr. Emerson is going to be talking about is this wonderful new study for HIV. And we're going to put the study up here. We're going to put it up here so she can talk about it. Okay. The new clinical trials that are getting ready to start in 2012. Okay. I'm going to share this.
2020.
2019. My God, they've already started. So I'm like 5 days from Sunday. I got that up there. Let me make sure you're splitting the screen. Okay, there you go, Dr. Emerson.
Okay.
Okay.
So basically, the information about the HIV vaccine is that there's been a lot of momentum for the research. The research has all been using clinical trials that experiment with mice. So there has not been any human research thus far. The only thing that there's human evidence of use in is Truvada, which is PrEP. And so for the HIV vaccine, there's been effective proof of preventable vaccine will teach the body how to prevent new HIV infection. Vaccines are the most powerful public health tools available. An effective vaccine remains still years away, but this gives us more reasons than ever for hope. Researchers are expanding on the results of a 2009 trial, again, not using human beings, in which the vaccine could reduce the risk for HIV infection. They're also pursuing new grounds of research with novel vaccine strategies, including a broadly neutralizing antibody that will target a wide range of HIV strains. At the same time, it's also exciting work in the efforts to understand if and how to cure HIV in people who are already infected. For this timeline, the work is long and uncertain. So that's not even years away, it's completely undetermined. Advocacy is needed to sustain the momentum. But for this present research, we're showing that the HIV vaccine that they're working on would prevent two kinds of HIV. One is the prevention. So the prevention of the virus would reduce the risk for people who are HIV negative. And it would teach their immune system to spot the virus if exposed to it and block it from causing infection. So that's one type of vaccine that's being experimented on. The second
But there's
type
still
of
no
vaccine,
cure, right?
huh?
There's still no cure, correct?
No, there is absolutely no cure, and there is no effective vaccine on the market. They just want to begin human trials of a vaccine. So we are years away from having an effective vaccine on the market. There is no vaccine, there is no cure. For people who are HIV negative, but high risk of becoming HIV positive, meaning a commercial sex worker, an IV drug user, a person who's having sex with somebody known to have HIV, men having sex with men in anal receptive sex. These are the categories who can benefit from taking a medication only if they're HIV negative. The medication helps to prevent their body, like what I just
And
described,
what is
from
the
being
what
infected
are
with
the
HIV.
how much does it actually? Okay, let's get a couple of things understood. The vaccination, the Truvada, is that
Medication.
a
It's not
pill?
a vaccine, but the medication that reduces your risk is called
That's Truvada.
Truvada or PrEP.
That's called Truvada. But
Right.
what they're
PrEP,
getting, the new trials,
PrEP is the medical term, but Truvada is the brand name.
Okay, what
So
about these rumors?
Truvada has been on the market since 2012, but not for general use and not as a vaccine. Truvada is on the market as a medication for HIV negative, very high risk behavior persons. They take the medication and it reduces their risk for becoming HIV positive with their high risk behavior. That's it. If you're already positive, the only hope is treatment. And so in the year 2015, the studies found that only about 63% of all people known to be HIV positive were participating in treatment. And out of that 63%, only 49% actually had continual HIV treatment. So if people that are HIV positive, they have to receive treatment. And if the treatment is effective, it will reduce their viral load to the point where it's undetectable. But an undetectable viral load has only been achieved by about 50% of all people that are HIV positive. And that's because many people are positive and not seeking treatment.
Okay,
The second problem is 1 in 7 people that are HIV positive do not even know that they're positive. So that's another problem.
Okay, let's break it down to the lay people. Now, if you are the average, because apparently HIV is spreading very rapidly among African American women.
Yes.
In some places is one out of every five one out of every 5 Black women are already HIV positive.
Especially in the Atlanta area, yes.
Yes. So if you're part of that 4 out of 5, Truvada really isn't going to help you.
No, if you're the 4 out of 5 that are negative, Truvada will help you, because if you are actually individually not in a monogamous relationship, then you are actually at risk, because the heterosexual men around you have a higher percentage of HIV infection. The prevalence is so high in Atlanta that if you have multiple sex partners and you're not consistently using condoms, you have actually a very high risk of infection. And so you could benefit from Truvada. Taking Truvada is a one-on-one conversation between a person and their healthcare provider based on what are their risk factors, what type of intercourse are they having, and with what gender.
Now, just being practical, taking this Truvada, how much does it on average reduce your chances of getting HIV? Say, and you're in Atlanta.
If you're actually taking the medication
on a daily basis, right?
Every day, it can reduce your chance by 99%. So it's 99% effective. And
kind of like the pill.
In whom there has still been an infection are people who are taking multiple medications and have multiple different health problems. So there were other things contributing to the medication potentially not being effective in them. People who consistently take the medication have a very good chance of remaining HIV negative.
Now, is it like the pill where they say it is 99% effective if used correctly, and then we see 75% of births
Yes.
in the African American population are unplanned because of
Yes.
some type of
Right.
birth control
They
failure?
took an antibiotic, they missed a day, they took it late, some direction was not followed. Okay. So, yes, Truvada is the same way. If you do not take the medication as directed on a consistent basis, your chance totally changes. So your risk factor could completely change within a week's time span based on your use of the medication and your consistency or lack thereof. Absolutely. Truvada is use dependent.
And so, what are some of the side effects of Truvada?
Oh, they're major side effects of Truvada. So there are the common side effects and then the uncommon side effects. Let me go back to the study.
Now, these
Okay.
kind
It's
of things that,
associated first and foremost. The most important thing about Truvada is that it's toxic to your kidneys. So that's called nephrotoxicity. And Truvada is known to have nephrotoxicity in about 1 in every 100,000 people. This can develop late in the course of the therapy, and the damage to the kidneys can result from the interface of the medication with your own DNA. So that's what's really happening.
you're talking
Then
about super kidney
2% of
failure, or
patients,
just Dr.
go
Emerson,
ahead.
you're talking about super kidney failure, as in I'm going to get on this medication and I'm going to take it. The longer I take it, the more chance I increase my risk of losing one or more of my kidneys.
That's correct. Damage to the kidneys is time sensitive. So the longer you're on the course of therapy, the more the risk of kidney damage. So once again, this is a medication that's not been approved for general use, nor has it been approved as a vaccine. This medication specifically is for people whose behavior makes it so that they are very high risk for contracting HIV with just condom use alone, which is inconsistent in most of these populations. They're
So
not
what is the
consistently
likelihood?
using
What is the
condoms.
likelihood of somebody who's dumb enough not to use a condom
Right.
being smart enough to take a pill every day at the same time?
Well, that's a very good question. And once again, it's a matter of behavior. And so, what studies have found is that some people, such as prostitutes, such as those who are being sex trafficked, may not be in a situation where culturally it's acceptable for them to pull out a condom and use a condom. So, they may actually benefit financially, psychologically, and even in a very emotional way from the lack of the use of condoms. Use of condoms is a very cultural thing. So even in certain cultures where they do body piercing, the condom use may not be as effective if there's actually a piercing that penetrates and breaks the condom. So any healthcare provider that's providing counseling about who is the population that should really be using Truvada really needs to have a very sensitive understanding to whom they're speaking with. Condom use in the case of, let's say, marital infidelity may be very simple. But in the case of somebody who is being sex trafficked and in a situation that is really not voluntary, she may not have the option of condom use. And in that person, she can reduce her risk for HIV infection by consistently using Truvada.
But if she's in the sex trafficking business, what is the likelihood that she will be able to voluntarily seek medical care? Doesn't it sound like this is something that her handlers would do to protect their own commodity, so to speak?
Yes, making sure that sex traffic workers and basically,
Give me
commercial
1 second.
service
Keep
work,
talking.
any commercial service worker should absolutely be receiving regular ongoing medical screening. That, like you said, that protects your own commodity. As a pimp, as a handler, if you have your sex traffic workers regularly screened for HIV and for sexually transmitted diseases, it also makes sense for any commercial sex worker to be regularly taking Truvada. They are a part of the population that was approved for use by the FDA in 2012. That's really important.
Okay, I'm sorry. Can you hear me?
I can hear you. You're still
I mean,
here. We're still
here.
talking it up about Truvada, about the HIV vaccine, what's been released as of 2019. All of this information is hot off the presses for 2019.
I mean, are we doing
Vaccine
ourselves?
research starts in the lab where scientists develop vaccines that they believe have promise. The next candidate is to test the vaccine on animals. If a vaccine shows evidence of safety and potential efficacy in animals, then it can move to testing on human beings. And that's where we're at with the HIV vaccine.
Now, let me ask you a question. This is a very, I know doctors do no harm, but is it better for society in general to turn HIV into a chronic disease instead of a fatal disease? Because in some countries like Ghana, they have refused additional treatment because the shorter a person's life expectancy is with HIV, since they can't cure it, they have a longer time to spread it. So aren't the pharmaceutical companies basically saying, we can't cure it, or our primary goal is not to cure it, it's just to reduce the spread somewhat? There's still a percentage of people that are going to spread it, they're going to contract it, but we'll have more and more customers that are coming in to get the Truvada, and they'll live longer on Truvada.
Well, the key is really the effectiveness of the message of Truvada. If truly the people at risk take Truvada, then the incidence of infection will significantly and dramatically decrease. So, as example, the president in his State of the Union address in February of 2019 stated that he wants a 90% reduction in the new HIV infections over the next 10 years. And to make this 90% reduction, he's going to target the 40 counties that have the highest rates of HIV and the 7 rural areas in states that are disproportionately affected by HIV. So all of this behavior actually reduces the number of people that would need HIV medication. If you reduce the annual infection rate, you've made a significant difference. So in the year 2016, 39,782 people were newly diagnosed with HIV. That's just in the United States. Worldwide, 2 million people were diagnosed with HIV worldwide. So once again, if you target the populations where the new infection rate is highest, and you target those populations and you intervene such that the treatment you're giving prevents the incidence of the spread, you prevent the transmission within those populations, you will actually substantially increase your rate of HIV negative persons remaining in the US. You will change the statistic that is the incidence of HIV on an annual basis. The incidence is impacted by impacting the hardest hit populations. So like you said, Black women in the South, men having sex with men, commercial sex workers, those persons that are sexually active and inconsistently using condoms with multiple sex partners, and of course, IV drug users. When you target those populations, then you're going to affect your incidence rate on an annual basis, and that will affect the overall prevalence of HIV in the US and
But
worldwide.
are we just really are we just really kidding ourselves about this? Because look, I'm looking at the screen, follow the mouse. It says in San Francisco, the number of new infections citywide went from a record peak of 453 in 2012 and down to 197 last year in 2018. Now, in 6 years, in 6 years, it went from 450 down to 197 new spread of disease. Now, could that be because a lot of people died off from 2012 and weren't able to spread it?
So again, that's an excellent question. And it comes down to how do we interpret statistics and how do we understand them? So it's really important to understand this statistic specifically is not looking at the overall prevalence of HIV, which would account for persons who may have died in the previous year. This is looking at the new onset of HIV, new people being diagnosed. So the only way to reduce in San Francisco new people newly being diagnosed with HIV is to target the homosexual population, gay and bisexual men of all ethnicities and all socioeconomic classes. You focus in on them and you intervene to decrease the transmission within that population because they account for the overwhelming majority of new cases of HIV. So if we look at the year 2017, African Americans accounted for 43% of all new diagnoses in the United States. And the Hispanic population represented about, 26% of all new diagnoses of HIV. So again, certain populations, ethnically, as well as based on their sexual behavior, have disproportionately affected the incidence of new infections. In San Francisco in particular, they're looking at the homosexual population and what was the incidence in that population. So if we look at incidence within the homosexual population, it's much higher than incidence in the overall US population. So
Yeah,
that's just
about basically since 2012. Since 2012, we've gotten about a 60% reduction in the number of new cases. This is after, I don't think there's anybody in the United States over the age of 12 who hasn't heard about, the use of condoms. Now we have Truvado's been out since 2012.
That's correct.
And even with Truvada, we've only reduced it by 60%. I know we want to get to like 90% reduction.
But once again, as we talked about, people are not using Truvada consistently. So those target populations, you still have to do a better job at the public health campaigns that target awareness, health education, and actual compliance.
Now this Truvada
who need to be taking Truvada are not taking it.
How much does it cost and who's paying for it?
Well, see, that's a great question. So once again, the president had an initiative in February of this year that he's going to decrease the incidence of new infections by 90% over the next 10 years by diagnosing, treating, protecting, and recognizing and responding. So how are you going to do that? If people don't have health insurance, they cannot afford that. Truvada is on an average $4,000 on an every 2-month basis. So if the insurance company's not covering that, and Medicaid does cover that for an at-risk person, if you're in an at-risk category, it's going to be covered. But if you have private insurance, it may not be covered. And if you're uninsured, then definitely that's an out-of-pocket expense. So
okay, so
that's an excellent point. How are we going to drive down the incidence in this at-risk population if they can't afford the medication?
Yeah, basically, it looks like we're sitting up here looking at something that is $133 a pill.
You got it. You got it.
$133 a pill versus condoms. What are they? $5? $3?
Exactly. Exactly. So again, the one is common sense, but it's not practical use. In these at-risk populations, there is a low use of condoms. And that has been shown in multiple different studies. That is responsible for the overall STD rate as well as the transmission of HIV in these communities.
You
So
know,
it's very serious.
looking at $133 a pill rate, and you're sitting up there going, okay, this is for the at-risk population. What is the likelihood of the at-risk population? I know there is a likelihood, but what is the likelihood of the married monogamous guy getting HIV? Why should he care about this 133 using taxpayer dollars to give this marginalized part of our population $133 a day just so they can continue risky behavior?
Because of the domino effect. As a heterosexual monogamous male, there is still a risk of infidelity within the lifetime of that marriage. It can be calculated what percentage of all marriages will have infidelity and how frequently in a lifetime. So, at risk for that, if the prevalence of HIV in your overall region increases because it starts in these at risk populations. It starts with men who are only having sex with men. It starts with only IV drug users. It starts with only commercial sex workers. But as the domino effect of sex, these persons then are having sex with other people in the community. So as the prevalence goes up, ultimately, they're having sex with bisexual people that are more low risk. And that is where now somebody in that marriage has an infidelitous one night stand. And that changes everything thanks to the prevalence of HIV in that region. Just like you just described Atlanta, you could be a heterosexual woman in Atlanta. And if you are Black and more likely to date and have sex with men of color, your risk for HIV could be as high as 1 in 7 to 1 in 10. So, as you allow at risk populations to have a higher and higher uncontrolled prevalence, it has a domino effect that ultimately affects you, your children, your pastor, everybody that's a sexually active adult.
So what? I mean, wouldn't we be better served? Wouldn't we be better served in this whole thing about education? Because don't forget, there are calls right now to decriminalize spreading HIV.
Right.
I mean, to knowingly spread HIV. So if you're on Truvada, let's just say hypothetically you're on Truvada,
Okay.
and you think like a lot of women unfortunately think they're being fairly consistent in taking the pill. But oopsie, I took an antibiotic
Exactly.
and Truvada is not effective. I but I tell my partner, my partner, since I'm in the sex trade because I'm high risk. I tell them I'm on Truvada. I know I'm clean because I'm on Truvada. Now, how often do you have to go in to get a checkup to make sure you haven't accidentally oopsied on Truvada so that you're not
Every 3 months, every 3 months. So Truvada is not like the birth control pill. And once again, whereas millions of women are advised to use a birth control pill, it's considered FDA safe. That's not the case for Truvada. Truvada is recommended for a very specific
no, I'm getting that.
at-risk group
I'm
of
saying that's what I'm
people
saying.
that have to be tested every 12 weeks. So if
Okay.
you don't go in for the testing your renal function, testing you for STDs, and testing you for HIV, then you don't know that Truvada is working. And you don't know that you haven't suffered the side effects of Truvada also.
So
So
what I'm
all
trying
of
to
those
get
are
at,
very real risk.
what I'm trying to get at is a false sense of security. Does if you're in that industry, let's just say
You don't
hypothetically,
have that security. You don't have that. You go and you follow up every 12 weeks for
no,
that
I
security
get that
because you're
you
right.
try.
The compliance is low.
No, I'm saying that what I'm trying to get is the risk to the casual persons who go into that population. Say like the men who may every now and then be on the down low. And so
Okay.
they frequent that population. They think,
Okay.
okay, I'm with a man that's on Truvada. These people
Right.
have, okay, so they go in every 12 weeks, but they went off their medication consistency within the first 4 weeks.
Right.
So now they have this 8-week window of opportunity in which they can contract HIV as well as spread HIV.
Absolutely. That's a fact.
So regardless of whether or not someone,
Not foolproof.
because I'm very concerned that people will say I'm safe because I'm on Truvada. So just because
They do, and that's a false security, and you're absolutely right. There is no security until the time of testing, because the only person otherwise that's holding you accountable is you. You know your behavior, you know your consistency. Your partner does not know that. Your healthcare provider does not know that. So the only time you're receiving healthcare provider endorsed security is every 3 months. Otherwise, your security is your own checks and balances to your ethical behavior and your accountability to your own sex partners, or if you're an IV drug user, then the other drug users. That's the only accountability. So it's absolutely, the risk of absolute failure and spread of the virus during that time period. You're not monitored daily, not even weekly.
I mean, I'm looking at all the different trials on the new idea for the viruses. I'm going to go to that screen real quick so you can see. They're putting a lot of money into the potential for an HIV vaccination. I'm going to switch screens real quick, lay here and bring up another one. I'm going to bring up this one real quick. I mean, this one is from Forbes. Let me find the Forbes one. Let me see. Here it is, Forbes. Now they're starting clinical trials 2019. Forbes is hoping that will lead to a vaccine by 2021. Here you go. 2021. But is this just a means to keep the public, how many times have we heard, since 2012, they were going to have, in 3 years, we'd have a vaccination. Now we're in 2019.
The studies actually show, and again, the facts are the promising results which appear in immunity suggest that researchers are one step closer to developing the HIV vaccine, a major goal of medical science since the virus was identified in 1993. So that's how long our chain has been jerked about getting a vaccine on the market, 1993. So we're more than 20 years into this journey, and we still have not had effective human trials that demonstrate a widespread across the board vaccine that can be recommended to the general population. So no, regardless of what they're saying, the human trial has yet to be proven effective. It's yet to be even underway. Like you said, it's only in the past couple of months, and really November of 2019, which is last month, that we started serious discussion about a vaccine for HIV.
You got the HVTN 70T trial, the Embucado and the Mozia, whatever.
And those were not in the US. So once again, that's a very specific population, and those trials actually cannot be generalized globally. because they were too specific. So the trials that are be valid to be applied globally have not even been done.
So is this, as part of me is a cynic? I'm sorry, I'm just a cynic.
But
Not a
that's
big
what
fan
we're here
of.
for.
I'm not a big fan of the pharmaceutical companies because of the limited recourse that we have against them as
Absolutely.
consumers. So one of the things that I am most concerned about, what if there's the notion that we are just dangling this carrot out in front of people's faces for the ideology of keeping up funding? What if they know that there's really there it is. There's really no likelihood of a cure in any of our lifetimes, but instead they are dangling. I'm gonna show you this one article, like totally freaked me out because they were open and honest about why they needed to keep HIV, the idea of the prospect of HIV virus coming very soon. There is no momentum and promise in the search for an HIV vaccination. An
Right.
effective preventive HIV vaccine would teach the body how to prevent HIV infection. Vaccines are the most powerful public health tools available, and an HIV infection would play a powerful role in ensuring the end to the AIDS epidemic. But that will also, if there's no AIDS epidemic, there's also a lot of industries that would go out of business. While effective vaccines remain years away, there are some reasons for hope than ever before. Research are expanding the results of the 2009. We were just talking about the 2009 trials that showed for the first time that a vaccine can reduce the risk of HIV infection. So we've been on this now, for all these years. And it says, despite substantial progress in understanding and treating HIV, existing tools have not effectively controlled the epidemic. We know that. The International AIDS Society and the Lancelot Commission recommends that global treatment efforts should be complemented with stronger investments, there's the word, in primary prevention, including research to accelerate the development of preventative vaccines. So what if the whole idea
that the newest research and the newest vaccines are coming at a different approach than the previous vaccines? That's what the new studies are showing. That whereas the previous vaccines were really trying to target the virus itself and actually making the virus ineffective, the newer vaccines have focused on expanding the body's own B cells, which are very rare. But if they target them, which they have in the laboratory, and they expand these B cells, the B cells can be paired with cells that are actually autoantibodies against the HIV virus. And those antibodies are what bind and actually stop the virus from penetrating the body. So it would be the body's own immune response being augmented that allows the body to protect itself against the HIV virus. So that's the difference with the newer vaccine. That's really the new information, because you're right. Otherwise, it's information from 2009 that has been recycled to try to get to the point where we're having a breakthrough right now in 2019, 10 years later. So again, the Fred Hutch Cancer Center that came forward with this new information saying that there's hope for a new vaccine. We don't know that there's hope for a new vaccine, but what we do know is that they are, instead of targeting the virus itself, actually targeting protein chunks that are then targeted to the body's own rare B cells. And those rare B cells are producing, what are they calling it?
ENV protein. I'm looking at one of the ENV protein. Normally,
Right,
multiple
but
copies
right, the
of
EMB,
this
that's a
drug,
name of a
EMV.
protein that basically binds with the HIV virus to prevent the infection of the body. But the immune complexes that the body creates, it's making its own immune complex. And so it's identifying the rare precursor beta cells and anti-idiotypic antibody. That's the name I was looking for. It creates an anti-idiotypic antibody that recognizes the B cells and then expresses a specific antibody against HIV. So as the body creates this new idiotypic antibody, that's what binds to the virus and then prevents the virus from actually infecting and invading the body. Those cells expand. So that's the new research by the Fred Hutch Cancer Center. That's what they're now moving towards. But is there a momentum to just keep the fire going where nothing is coming forward? That's an ethical question that we have to pose, because thus far we've gone almost 30 years in this research process and gotten barely anywhere. So I would say, viewers, we need you to comment on this. What has been your experience with HIV virus, infection, disease? Have you experienced and lost people in your life, in your profession, or globally to the HIV crisis? Have you noticed your community being impacted by this? So that we can come back for part 2 and give you more specifics about where we're at as a country and where we're at globally with an HIV vaccine. Is this a reality, or are we really going in circles and running up the pharmaceutical bill?
Hey, I just want to give out a quick shout out to D. Durrell that joined us. He's very fascinated to find out how doctors and lawyers are working together. As I said, what really intrigued me was the fact that there was a law firm out of New Jersey, I believe. Let me share this screen again. Because being able to talk to a learned colleague and say, hey, what's going on with this this talk that there's a fake HIV vaccine out there. What's going on with that? And as we speak, Facebook, if you look on the screen right now, there's a law firm that is running ads already. Absolutely. Lining up people saying, hey, the ad, which runs on Instagram as well as Facebook, is paid for by the Virginia law firm of KBA attorneys. It cites unspecified bone and kidney conditions as side effects from Truvada, dangling the prospect of financial compensation from future lawsuits against manufacturers, Gilead Sciences. So what we're having right now is, as people are trying to find a way to get these at-risk people to take $133 a day pill. Right. You have lawyers like me that are saying, hey, go get on that study and come see me. You could have just potentially made yourself a couple $1,000s.
Yeah. Or more.
Exactly. So, I mean, I want the truth out there that if you're at risk,
yes,
I mean, do go in and take the Truvada. It's not going to be a lifetime commitment. No. You need to get off it, would you say, within 2 to 3 years at most?
That's exactly correct. That's correct.
So this Truvada is a product that is on the market to deal with those who have a temporary need.
Yes.
Because of economics, because of
high
just
behavior,
poor life choices. Yes. Sorry.
Life choices. Yes.
But at that point in time, you want to get on Truvada because you want to do better. And you want to tell your potential partners to use a condom if at all possible, even if you are taking Truvada, because you might have mistaken it. And correct. If you do meet someone that says, oh, you don't need to put on the condom, I'm on Truvada, ignore them and go ahead and put on the condom. Is that pretty much the way?
That's very accurate. That's very accurate. Yes, absolutely.
And if you are banking on a big payday because you've taken Truvada and you discontinue it and you still think you're going to get a payday, we should know that studies show that any bone density reduction is usually only 1%, and it's usually self-correcting. In other words, it doesn't do long-term damage. Whereas stopping taking Truvada can do long-term damage if you're still in that high-risk behavior category.
Amen.
So, Dr. Amerson, I appreciate you being on. We've been on a little over an hour. I want to keep the show short and sweet. And so, hey, people in the comments, tell me what else you want Dr. Amerson
Yes.
to, any stats
This
on
is a
HIV
very
and Africa.
in-depth conversation that we can continue, and we need the viewers to direct us. Where are your areas of interest in this major health epidemic?
Okay, Deidre, we'll have a new show on, we'll have the actual stats on HIV, and we'll actually talk about, the difference in treatment between the way the European model and the African model and the United States model. Which one is being more effective in actually stopping the spread of HIV? Because Africa, we do have some cultural differences, multiple wives, higher tolerance, so to speak, for men cheating on their wives or girlfriends than we do in the United States because of lack of self-sufficiency of the women and their inability to refuse sexual advances. So those are important things that we want to talk about. But right now, we want to make sure that people who can get on Truvada are not given a false sense of hope. They're not given a false list of narratives, and they're not getting on it just to try to catch a case, because it's not going to work. Okay, everyone, thank you for joining in to Nichelle's World with La Doctora. Dr. Efrae Amerson will be back next week with some more exciting topics. Y'all have a good night. Bye-bye.
Happy New Year, everybody.
Happy New Year.